Thanks everyone for joining me on this journey of what it is like to be a veterinary nurse, scrapbook style. Just to introduce myself, my name is Courtney and I'm a registered veterinary nurse here in England. I'm originally from New Zealand where I trained and qualified, but after 8 years of working in general practice, I moved to sunny Australia in 2015 to pursue an anaesthesia dream. I wasn't there for too long, but it was definitely the quality, not quantity of time I spent there, which helped pave the way to who I am today. And in 2016, after I bought another one-way plane ticket, I ended up in the UK, getting registered with the RCVS, learning a whole new lot of drug names, and confusing people with the way I pronounced pen or bed, or a writing pen or a dog's bed, for those of you who still can't understand me. So the reason I've called this presentation More Than Just a Veterinary Nurse is because of how I've seen many students and qualified nurses doubt themselves throughout their training and career. When they feel knocked down and unsupported by colleagues or clients, I often overhear them say they are just a veterinary nurse. And so I wanted to squash that thought right now, defunk that concept right now, because you are so much more than just anything. Your training and your qualification is a passport to so many opportunities wherever you want to be in the veterinary industry and wherever you want to be around the world. So us veterinary nurses think differently to a lot of other people. We're empathetic, patient, nurturing, and we have this passion for helping both people and pets. We're an advocate for animals inside the hospital walls and outside of them too. We're an advocate for people in the community by educating clients and sharing animal welfare standards. Another part of what makes us just more than a veterinary nurse to our patients is the support and knowledge we share with our colleagues, students, and within the industry. One of my favourite things about being in veterinary medicine is when we provide support and knowledge, we actually do inspire others to do better, which in turn will always benefit our patients. So it really is a full circle. Because we are all more than just anything, I wanted to share with you my journey to prove to you that you can become absolutely anything you want to be. And I want to show you how I opened my veterinary nursing passport to find my dream job that I'm excited to get out of bed for every single day. You'll see my ups and downs along the way. It has not been a smooth ride. So I kind of want it to help remind you that you are starting an entirely new chapter of a very fulfilling career, and it is exactly what you make of it. And then to finish, just some pretty cool cases that I've been a part of, just to kind of prove to everybody out there and myself that I really am more than just a veterinary nurse to those patients. So here it is, 2007, the first stamp on my passport. I studied full-time at Unitec in Auckland, New Zealand for 2 years. It was my very first taste of living away from home, making entirely new friends, structuring all of my time, and the worst bit, seeing blood. Actually hearing about blood. So I almost passed out listening to the veterinary surgeon explain how a male cat was castrated. So it was an interesting couple of years trying to get a training manual signed off when you hit the floor, whenever you saw something that should be on the inside of a cat or a dog. But alas, I managed it and I got through it, but still to this day I won't scrub into surgeries. And I sit down for anything that I think is too much to handle, like placing central lines, for example. It isn't a weakness at all, it's just being a human being, but it had literally been a part of my career for over 10 years. During my first year of study, I got a job as a veterinary receptionist, and I ended up staying in that practice for almost 6 years. So after this, I wanted a new challenge, so I applied for a senior nurse and catering manager role in a different practice. And both of these clinics, though, I did spend a lot of time, like half of my career in them, and I learned so much and I had the best support from my colleagues. However, in 2014, I did feel burnt out, and it wasn't because of my rota, it wasn't because of the caseload, it wasn't because of demanding clients, it was because I had exhausted myself by trying to be every part of being a veterinary nurse. I was upset and frustrated with myself that I didn't know everything about worming treatments, the growth stage of kittens, how to wrap the best surgical kit, the nutritional content of every bag of food sold, where all the anaesthesia drugs worked in the body. And I started to feel really worthless, and I panicked and I actually left veterinary nursing. I ended up still in the industry, but I worked as a sales and marketing coordinator for a very big corporate group in New Zealand, and I loved it. I loved having targets and things to work towards. I loved helping the teams in the veterinary practices get inspired to promote their amazing knowledge and passion to clients and pets by doing dental checks and weight loss clinics, things like that. I also loved being around some very driven business brains. So after a year and a half, though, I had matured massively, but I did miss animals enormously. So that's when I went back into practice with the realization that I got fulfillment from having a goal, something to work towards, and by helping others along the way. So I ended up as a head veterinary nurse with an anesthesia passion. And I knew I had found my niche. I knew I wanted to pursue that passion of anesthesia, and I knew I wanted to share and support others in finding, what they loved about veterinary medicine. Sadly, that dream was cut short, and through blurred vision with teary eyes, I decided I needed to get out of New Zealand. Now was my chance. I had no job, no boyfriend, no apartment, no furniture, just a 25-year-old free spirit and her 2 tabby cats. So I really could be and do anything I wanted to. I finally had the freedom for that. So I booked a one-way ticket to Australia to work in a large veterinary referral hospital in Brisbane. It really was a whole new world. Getting to focus on high-level anaesthesia care and theatre nursing only fueled my fire. And I learned so much so quickly. I made a ton of new friends. I had a new country to explore, but for the first time in my life, I also got a tan. But it really is all fun and games until you get knocked out. It wasn't blood this time. It was my head colliding with a bucking cattle dog that did not want to be restrained. So been there, done that, got the picture, always a laugh. After less than a year in Australia, I found myself once again having booked a one-way ticket to the other side of the world this time, so I could take the next step in my career. I knew where I wanted to work. It was one of the best hospitals in the world. I'd come this far, why not aim high? So I had emailed the head nurse of the Royal Veterinary College well before I'd even landed in the UK, asking for a job. And it was only when I got a reply saying, "Are you registered?" that I realised I had a few stepping stones to jump across first. So having landed in Heathrow on the 5th of March 2016 with only a few pounds in my pocket, I was sleeping on a couch and finding locum roles for the first few months I was here while I was studying and practicing for my OSCEs. And it's only once I became registered that I was still hungry for that RVC dream, until the next stepping stone popped up. In the meantime, I sort of got this email from the head nurse that said, "Please keep an eye on the job section of our website and wait for the next anaesthesia role to pop up." So I swear I looked at the website every single day. But until then, I not only wanted to work on increasing my chances of being a successful candidate when the time came, but I also just wanted to know more about anaesthesia. So this is when I enrolled in the Improve International Nurses Certificate. And that is also when I started doing veterinary anesthesia online through social media. So I have a real problem with retention of knowledge, and I find that I can only keep it in my brain if I've regurgitated it out to somebody else. So while I was studying my certificate at Improve International, I started doing VA. I met some amazing people. That's actually when I met Lou the vet nurse as well, and now we're really great friends a few years on. While doing my daily click through the RVC's job section, I had to blink twice because there it was, an anaesthesia role. Hallelujah. Part-time, who cares? It was a foot through the door. So the applications kind of closed when, and suddenly I realized it was in a couple of days. So I was in Europe at the time with a sunny summer month off, and nothing taught me patience like working on a CV and applying for your dream role while using your iPad with really shoddy hotel Wi-Fi. So when I did finally get it sent off, and then I got an email in the next few days with an interview date, I realized I had to get on the next flight home. So I landed in the morning, I interviewed at the RVC in the afternoon, and then I flew back into Europe the next day. So to say that I gave it everything I had is pretty much an understatement. But then finally I was ecstatic because after a few years, I landed my dream job doing exactly what I wanted. And the thing is, I knew I had made it happen. I didn't wait for kind of opportunities to come in front of me. I really did grab them. And I would have never imagined that I would be someone who got to share everything I knew about anaesthesia with the next generation of vets and nurses, or that I would actually even go on to speaking and writing about anaesthesia. So that is my journey. It was a bumpy ride. So let's first of all kind of define what people think success is. It is a noun. It is a word used to identify a class of people, a place, a thing, and it does mean the accomplishment of an aim or purpose. So while I certainly feel like I'm on the right track to fulfill what I wanted from my career, it really was no straight line like what you can see here. So there is the excitement of studying. There's the confusion of finding yourself in your first job. Then there was kind of like me panicking and leaving the industry. The next step forward was me realizing I actually wanted to be back in a veterinary practice as a nurse. So that was me landing my dream job as a head veterinary nurse. But then there's actually some people who don't want you there. They don't like to kind of praise success. And remember when I said that I booked a plane ticket through blurry eyes and tears falling from my face? It was because I actually got fired. I worked with bullies and liars and hypocrites, and unfortunately some mean people really can push you out, and I think it's completely up to you on how you handle that situation. So I had to drive up and over that speed bump full steam ahead. So that is when I moved to Australia, and then I moved to the UK. So sharing my passion with others through veterinary anaesthesia was kind of the next highlight in my career, getting my dream job. And then the best bit was really knowing what my worth was. So what can I do to make myself happy in my career? How can I improve patient care every day? And how can I have a laugh with my colleagues along the way? So definitely not a straight line. It was a squiggly line, ups and downs. I was questioning myself a lot. I felt that other people were questioning me too. But ultimately, I tried to find those opportunities and take a few steps forward as I was moving through my career, no matter how hard things got. And I think what's important to understand is that you don't need to wait around for things to come your way. If the opportunity doesn't knock, then build your own door. You can go out and you can find things. You can put yourself forward for opportunities. You don't need to wait for them to come your way. So moving on to some of the cases, I often get asked what my favourite type of case is, and it's so hard to choose. But I did want to share with you two cases. One's an ortho anaesthesia, one's a neuro anaesthesia, because there are some aspects of these cases that I think are really excited to be a part of when you are a veterinary nurse. So it really emphasises what we are capable of, that we aren't just anything. We actually are superheroes. So the first one is just going to be talking about local anaesthesia, and then the second one is going to be how understanding anatomy and anaesthesia can actually impact how a patient will recover from an anaesthesia as well. And this is all to do with a cat that's got a brain tumour. So where I work, we have a lot of freedom to discuss and plan protocols with our anaesthesia specialists. So we are fully supported and given the final okay in what decisions we think are best for the patient. But it is exciting knowing that you have the thought process and the ability to bring it up and to mention things as part of a patient care plan. So let's meet Benji. He's a 4-year-old male and Thai golden retriever who was having the best Sunday ever until he fell down a bank and suddenly became lame on his left hind leg. So at his primary veterinary practice, the examination found that he was 10 out of 10 lame with a positive cranial draw, meaning that the tibia can slide backwards and forwards when the femur is held in place. So it causes a lot of pain and discomfort. And it does suggest that his cranial cruciate ligament has been ruptured or torn. So it's called an anterior cruciate rupture in humans, but we call it a cranial cruciate ligament rupture. He was sedated for radiographs where it was confirmed that his stifle joint was not sitting where it was supposed to be and that there was some joint swelling as well. So Benji was booked in for a tibial plateau leveling osteotomy, or a TPLO, the following day. This procedure means that the dynamic on how the stifle moves is altered permanently. So we can see here that this is the normal placement of kind of the femur and the tibia with the two ligaments there, and then we've got a rupture of the cranial ligament, meaning that the femur and the tibia are at an odd angle rubbing against each other. So what we end up doing here is that we make a cut to the tibial bone, and then it's rotated to a position where the femur and the tibia communicate, so it no longer slides backwards, and then it's plated in place. So this actually eliminates the need completely for the cranial cruciate ligament altogether. In preparation for a surgery, Benji had been given a wet food meal at midnight the night before and no breakfast on the morning of his surgery. So a prolonged fasting period has been associated with an increase in incidence of gastroesophageal reflux or regurg. So by feeding him at midnight, we kind of eliminated a good few hours of potentially a prolonged fasting period. So when we tell owners that they can have, feed dinner as usual the night before, but nothing from midnight, the owner will just feed the dinner at 8 o'clock to their pet and then not feed breakfast. So by the time they come into the practice, they get their pre-medication, the surgery starts, it could be well over 12 hours of fasting time. So it's a bit longer. So what you can do is kind of rephrase that sentence to clients and say, feed a small meal at midnight instead. An IV was placed into his right cephalic vein, so this pre-medication could be given via this route. It means that the doses can be lowered and the onset of action for the drug is immediate. His pre-anesthesia exam was completely unremarkable. He is young and healthy. His TPR was normal and his pre-anesthesia bloods were also normal. So the next step in our anesthesia plan is to anticipate his needs, and this helps make a really tailored approach specific to him rather than a blanket protocol that might not fit every single patient. So our considerations for him: he's young, he's healthy, he's very bouncy, so he will definitely benefit from a sedative. An orthopedic surgery as well is very painful, so he does need an analgesic that's nice and strong. So we'll give him something systemically, and we'll also do a local anesthesia block specific to the surgical site. So he is a large dog, and a local anesthesia block that we could do, for example, is an epidural, but this would mean that he's unable to walk post-surgery for up to 12 hours and unable to void his bladder. So it does make management a little bit difficult for him post-operatively. So we have opted for a different local block, which I'll talk about next. He will need a fast-acting induction agent, so we can place an endotracheal tube, and then we will be able to maintain his anesthesia with a volatile agent and oxygen. Some anesthesia related vasodilation and bleeding may be encountered, so we will provide IV fluid therapy to support this and support his blood pressure during the procedure. It can also help with any hydration issues from being fasted. So as pre-medication plan for sedation and analgesia, both medetomidine and methadone were used. Medetomidine, it's an alpha-2 adrenergic receptor antagonist, which has receptors in the brain that cause sedation and relaxation, and receptors on the blood vessels as well, which cause vasoconstriction. So we're all very familiar that when we use a drug like medetomidine, Medidor, or any other brand name for medetomidine, you do get that very low heart rate. So that is actually a reflex from the vasoconstriction where the drug is working on the blood vessels. So when the blood vessels constrict, the heart rate goes, whoa, I can't pump into these tight little pipes anymore. I'm just going to lower the heart rate. So it's a reflex. With this, we do get some bradyarrhythmias. We do get something called a delayed arm to brain time. So it just means whenever we inject a drug from the peripheral catheter, like the cephalic catheter in Benji, it will take a long time with a slow heart rate to get to his brain, for example. So that's definitely going to impact how we induce his anesthesia. The other amazing thing about medetomidine that I absolutely love is the sedation is very reliable. With acepromazine as a pre-medication, it is a little bit hard to predict how an animal might behave when that drug is on board, but with medetomidine, it is predictable. They usually drop down and have a nice kind of flat type pre-medication action. So it does work within 2 minutes when given IV. It's nice and quick, and the best thing is it can also be antagonized. So you can antagonize the drug and get it out if there is an emergency, or if you would like him to wake up quicker. Methadone was the analgesic chosen because it is a full mu opioid receptor agonist, meaning it's a good choice for moderate to severe pain, and it does have a duration of 4 hours. So it's definitely going to be there before we cause any pain to Benji, and it's also going to be there for the post-operative period as well, and it can also be topped up. Anesthesia was induced with 1 milligram per kilogram of alfaxan. This is lower than the typical induction dose of 2 milligrams per kilogram because the sedation provided by the medetomidine was quite good. So we didn't need as much anesthesia drug to be intubated. So it's really good when we can use lots of little things during anesthesia just to reduce some of those dose-dependent negative side effects. It was given very slowly, like I mentioned before. He has what we call a delayed arm to brain time because of the bradycardia. So we didn't want to overdose him. We didn't want to just push in lots of alfaxan or any other induction agent and go, oh, he's still not asleep, he's still blinking, he's still swallowing. And that's just simply because his heart rate is slow from the medetomidine. We know that's nice and normal. So we just need to wait for the drug to get to his brain. So alfaxan does something very cool, and it preserves the baroreceptor reflex. So what the baroreceptors do, they sense pressure changes within the vessels, and they can cause dilation or constriction or make the heart rate increase or decrease just to make sure that there is a nice and normal constant rate of blood pressure within the body. So with most induction agents, they will to a degree cause some kind of vasodilation. And under anesthesia, the response to act upon this to make sure that the blood pressure stays nice and normal, that's also dulled. So something like propofol, for example, causes vasodilation and causes the heart rate to drop. Therefore, you do get a hypotension. But the cool thing about alfaxan is it preserves this reflex. So it means that as there is that inevitable vasodilation, the baroreceptors, they sense that change in pressure, and then they also cause the heart rate to increase to make sure that the blood pressure stays nice and normal. So it's one of my favorite things about the drug, but it is something to be aware of, that you might see an increase in heart rate when you use alfaxan, and that is because it is doing its job. It's not because the patient is waking up. Maintenance was provided in the form of isoflurane and oxygen in a circle system. So we're able to use low flow anesthesia. It's very, very cost effective. It keeps humidity in the breathing system. Also keeps them nice and warm. So we had a really high fresh gas flow rate initially, 100 mils per kilogram per minute, just to flush all of the room air out of the breathing system and fill it up with 100% oxygen and fill it up with the isoflurane that we wanted to deliver. After 10 minutes, however, once that system was fully saturated, we were able to turn the fresh gas flow rate down to 0.5 litres per minute. IV fluid therapy was provided at a surgical rate of 5 mils per kilogram per hour, and the AAHA has a really good resource on fluid therapy guidelines for dogs and cats, and there is a section in there for anesthesia. So for dogs, you can kind of use about 5 to 10 milligrams per kilogram, mils per kilogram per hour as a surgical fluid rate, and then it can be tapered out down lower depending on how long your procedure's gone for, and if they've lost any blood or anything like that. You can actually end up getting them onto a maintenance fluid rate through the anesthesia. So this is the exciting part. This is the local anesthesia plan. So the nerve block selected for Benji was a femoral and sciatic block. So as you can see in the white diagram down the bottom there, there's quite a few different blocks you can perform. So we're just going to go and get rid of the ones we're not going to do. So we are left with the femoral block and the sciatic block. So these two nerves have both sensory and motor fibers. So blocking them will stop any pain from being felt and also stop the muscle from contracting for movement. So by doing a femoral and sciatic nerve block, we're able to provide analgesia just to that leg, just to the leg that needs it, just to the leg that's been operated on. Whereas, like I mentioned before, an epidural might make him unable to walk or urinate for up to 12 hours. And it's very difficult for ward staff to kind of manage that and get him out to the toilet, and also have him stop freaking out that he's so big and he can't move his back legs. The exciting thing about this nerve block in particular is that it's all muscle based. So as veterinary nurses, we're actually able to perform this. So how do we find these two nerves? The femoral nerve here is seen in red and branches out to L4 and L6 and crosses what is called the femoral triangle. And the nerve sits cranial to the femoral pulse. And that is where we would inject our local anesthesia drug. So I do have a video coming up next. This block will block the nerve from the mid-femur down. And considering we're working on the stifle, it's perfect. The sciatic nerve is seen here in yellow and branches out of L6 to S1. It emerges between the greater trochanter of the femur and the ischiatic tuberosity, and it will block from the stifle down on the more caudal part of the leg. So a nerve stimulator was used to find the nerves. This is a little wee machine where you can see the electrodes there, the red and the black ones. They're connected to special kind of nerve needles that also provide a way for the local anaesthesia to go through the needle as well. So the landmarks I just mentioned before are used to find the approximate location of the nerve and where to insert the needle. And then you fine tune and you move around and in and out of the muscle until you see really strong muscle twitching associated with what those nerves are control of moving. So once the local anaesthesia is injected around the site, the leg stops twitching because the volume of drug that you are injecting pushes the nerve needle away from the nerve itself. So it stops twitching. It's not that it's made the nerve not, be sensitive to anything that quickly within seconds. It's just that you are moving the nerve away from the needle, and that's how you know that you've bathed the nerve in the good stuff. Another way of finding the nerve is also by using an ultrasound. So the hospital I work in, we do use both. We usually use the ultrasound. You are able to identify right where the nerve is, and you can put the local anaesthesia really, really close to the nerve. Whereas with the nerve stimulator, you kind of find in an approximate area that it is when the twitching gets really strong. So if you imagine that messages are sent along the nerve fibre like a Mexican wave, local anaesthesia is the kind of group of people that don't stand up and cheer. So the message kind of stops there. It doesn't go any further. So the group of people in this example is the local anaesthesia drug, which is bound to the sodium channels of the nerve fibre. So when it binds to the nerve fibre that you can see here, and it binds to the sodium channel, that Mexican wave cannot continue. It just kind of stops where you can see that red square of local anaesthesia. And it just means that the message doesn't go further. The brain up ahead has no idea what's going on. And it's kind of like if you imagine being in a stadium, there's a few people down in the bleachers that have no idea that some people didn't stand up for a Mexican wave. So they are none the wiser of what's been going on down there. The local anaesthesia drug that we chose was bupivacaine, 2 milligrams per kilogram split across the two sites, across the femoral and sciatic site. It was chosen because it does have a very short onset time. So it's working within 15 minutes, and it means by the time we do our final prep, move the patient to theatre and drape the patient, for example, it's working. It also works for about 6 to 8 hours, so it means that it's definitely going to be on board throughout the procedure, and it will also be on board through his recovery too, so it's perfect. It means that he might not need systemic analgesia through the recovery period until the block has worn off, which is really good. Here's a video here. This is me doing the femoral nerve block. So you can see that my left hand is palpating the femoral pulse, and I'm going just slightly cranial with it, with the nerve needle, and Georgia out to my right hand side there, just below the word femoral. She's ready to inject the drug. So what you'll see is the leg twitching, and then you'll see her draw back on the needle. Just make sure I'm nowhere near the femoral artery, there's no blood coming back, and then she will give the local anaesthetic block, and you can actually see the leg stop twitching as the local anaesthetic drug pushes away from my needle and pushes the nerve away from my needle. So I know I'm in the right spot here. And this white line here just kind of demonstrates where the nerve is running. It's a bit wobbly. There's Georgia drawing back. And there she is giving the local anaesthesia drug. You'll see the legs stop twitching there. So it's not because the local anaesthetic drug has worked that quickly. It's literally because the volume we're putting in, going through the needle, is pushing the nerve away from me. So I know I'm very, very close to it. The next video we've got here, it's a short video, and it's Georgia, who is actually an SVN at the time here. She's a student vet nurse at the time, performing a sciatic nerve block. So you can see the white line is just where the nerve runs, and she's got her left hand pinched as a landmark, and she's going right in the middle of it. And you can see the leg twitch. We don't capture giving the drug on this one, but you can just see the leg twitching, she's found the nerve spot, and you can also see the excitement on her face when she realizes that the leg is moving because she has put the needle in the right place. So it's quite exciting. So there's the leg twitching, and there's the excitement that she's hit it. So it's great. So from here, I would have done the same thing. I would have drawn back on the needle and syringe just to make sure there was no blood, and then I was going to inject the local anesthetic agent. Post-operatively, he is a very crazy boy, and we need to anticipate what kind of recovery he's going to have. The very low dose metotomidine that I gave as part of his pre-med, that's probably worn off by now. So I do want to give him another drug just to help smooth out his recovery period. So I know it seems wild and crazy that we use a typical, pre-medicant drug in the post-operative period, but the acepromazine is just going to be very low dose, 5 micrograms per kilogram, and it's just going to, make him nice and calm through his recovery period. So it's going to work on those dopamine receptors. It's going to make him nice and chilled, nice and happy. He's not going to wake up and thrash around considering we've just cut his bone in half. The next part of his recovery plan is that we will be given methadone based on his pain score, but he needed 0.2 milligrams per kilogram every 4 hours. And we started doing that after his local nerve block wore off. So actually there was a period of his recovery, of Benji's recovery, where there was no systemic opioid on board because that local nerve block was working so well. So what we did through the recovery period, especially on the 6 to 8 hour mark, is we did lots of pain scores. And when he started to kind of get that sensation back in his leg and indicate to us that he could feel his leg, we started with the methadone again. So we got that every 4 hours. We also gave him a non-steroidal, which is meloxicam or metacam as it's otherwise known. So this really does help with pain and inflammation. This is the inflammatory soup that you might be really familiar with. And what we also did was continue his IV fluid therapy until he was 18, just to provide that support to get keep his his blood pressure up, keep his hydration nice and normal, and help him excrete some of those anesthesia drugs. So that was the ortho anesthesia case, and one of my favorite things about that is that as a veterinary nurse, I was able to provide, local anesthesia under guidance and supervision from the veterinary surgeon, just to help smooth out his recovery. So I was a real advocate for him there. I was making sure he wasn't going to be in pain, making sure he had a nice, smooth recovery. And actually, local anesthesia does reduce recovery time as well, and they end up being out of the hospital much quicker, and it lowers pain scores. The next case we're looking at is neuroanesthesia, so keeping the brain happy. So let's meet Olaf. He's a 15-year-old male-neutered ragdoll, and in the last month he's had this history of behavioural changes. He's become less interactive, and at times he's been unresponsive and vacant. He's also become a little bit ataxic, and he's developed a head tilt. So his neurological exam was abnormal, and he was booked in for an MRI straight away. The MRI was booked for 12 o'clock. He had an IV catheter placed in his left fore. And his pre-anesthesia exam was somewhat unremarkable. If not, he was slightly bradycardic, so that's definitely a consideration. And something to watch while he's in the MRI scanner. In terms of the plan for him, do we need to provide analgesia? Not really. We don't kind of think he's in any kind of pain or anything like that. Do we need to provide a sedative? In this instance, the fact that he is neurologically abnormal almost is his own kind of pre-medication. So we don't really need to sedate him, but we would like to give a drug that can help lower things like our induction drugs and also lower the amount of inhalant anesthesia he needs to be on, because it's still a drug and it still has dose-dependent side effects. So we opted for butorphanol for him, 0.2 milligrams per kilogram IV. This will help to, like I just said, lower the propofol and lower the maintenance induction agent. And the good thing is it doesn't stay around for long. So it means that by the time we kind of finish the MRI, after 45 minutes or so, there's the butorphanol's worn off out of the system. So it will help with his recovery. Induction was with propofol, 3 milligrams per kilogram, and then we were able to intubate him, and maintenance was provided via a T-piece breathing system, and we used sevoflurane for him. So we used sevoflurane in neuroanesthesia because it does actually have a few properties that make it neuroprotective. It does help to maintain kind of the vascular tone within the brain and help maintain perfusion and blood pressure. We also provided IV fluid therapy for him at 3 mils per kilogram per hour. So once again, if you do have a look at the 2013 AAHA fluid therapy guidelines, there is a section on anesthesia, and it does talk about why cats have a lower fluid rate than dogs, and that's because they aren't little dogs. Dogs have a blood volume of 90 mils per kilogram, and cats have a blood volume of 60 mils per kilogram. So they actually do need less fluid because they have a smaller blood volume. That's why, but it's a very interesting read. So now we're in the maintenance phase of anesthesia. We've got our first few views back from our MRI, and we can see a brain tumor. So what we can see here is around that red circle is there is actually a tumor that is pushing his cerebellum. So it's a big cauliflower looking structure off to the right hand side of the circle. And what's happening is it's causing his cerebellum to herniate. So you can see here it's just popping out where it shouldn't pop out. In comparison, this is a normal brain, so you can see the difference. And it's a nice round cauliflower cerebellum in there on the bottom view, and then the top view is poor Olaf, who has part of his cerebellum herniating. So there are kind of only 3 things that can be in the cranium: blood, CSF, and the brain itself. So when you have something like a space occupying lesion, which is what Olaf has here, it's something that there isn't really enough space for in the very rigid bony cranium. So something has to give, and as a compensation, sometimes the CSF will shift, but in this case, once the CSF has kind of shifted to the maximum point it can, some of the brain tissue will start to herniate. So what can we do for him under anesthesia to help keep the brain happy and to help potentially limit the amount of volume in his brain? And one thing we can do is actually ventilate him and keep his end tidal CO2 around 33 millimeters of mercury, because if we do keep the CO2 a little bit lower than normal, we could actually cause a vasoconstriction. And with that vasoconstriction, we can cause less blood in the brain. We don't want to go too low and cause constriction to the point where we're compromising blood flow. But we can lower the CO2 just enough to cause a little bit of vasoconstriction. So as you can see here. And we also want to maintain a normal blood pressure. So the brain is amazing. It is able to regulate its own blood flow, but only to, just to keep it nice, constant pressure, but only within a specific range. So that's why we do want to keep the blood pressure nice and normal, as well as causing a little bit of vasoconstriction in the brain, just to limit the amount of blood that's also in the brain, just to not try and put too much volume in there. He's already losing part of his brain out the back, so we need to do our best. And I think that's the exciting part about being a vet nurse through neuroanesthesia, is you kind of sit there and you wait for the first few images to come through, and you think, oh my gosh, okay, the cerebellum's on the way out. What can I do? I can start giving some drugs, which we'll talk about next. But right now, immediately, I can ventilate him. I can bring down his CO2. I can cause a vasoconstriction. And you don't have to just apply this to big fancy brain tumor cases as well. You can also apply this to cases where you are anesthetizing a cat with head trauma. Say they've fallen from a high rise, or they've been hit by a car. They might have a prolapsed eye, or they might have a broken jaw, and they require anesthesia for that. So it's also something you can consider doing, keeping their CO2 a little bit lower, around 33 millimeters of mercury, just to reduce kind of the volume within the cranium. So recovery for him, how he's going to recover is also how he's managed during the peri-anesthesia period. So I talked about already, we're going to ventilate him, we're going to bring his CO2 down, but some drugs we're also going to do before we recover him is give him mannitol. So this is kind of a diuretic that will pull fluid from the tissue in the brain and cause him to wee it out. So once again, it's going to try and reduce the volume that's within his cranium, because there is already this big space occupying lesion. There's already a tumor in there that's taking up really, really valuable space. So this is just a sort of an infographic on what mannitol does. So mannitol is a really, really big blobs in this case, and they will actually pull fluid and shift fluid from brain tissue into the systemic circulation, and then you can wee it out. We'll also give a steroid as well. This can help move fluid as well and reduce kind of edema. We'll slowly turn down the vaporizer when we want to wake him up. We don't just want to kind of get him straight awake by turning the vaporizer off. We want to do it really slowly. And we do this just to reduce any chance of emergence excitement or emergence delirium or a rough recovery or anything like that. So I always say that we want to kind of cross the stardust nice and slowly. And then we want to wean the ventilator off and allow him to spontaneously start breathing again, start to get back in control of his breathing so that he can wake up. And we will need to keep him on IV fluid therapy because we are using some drugs that will cause him to have an increase in urinary output and potentially become dehydrated. So we want to make sure we're still putting the right fluid back into him. So those are kind of a quick walkthrough, two really, really cool cases that you may end up doing in your career. You may be able to provide local nerve blocks, when you are doing some orthopedic procedures. You may be able to anaesthetize a cat that has a brain injury, and you do need to make sure that they're going to wake up safely, they're going to have a safe anesthesia experience, and you're not going to cause any damage by performing an anesthesia. So I think these are two kind of cases that make me really proud to be a vet nurse. I found my niche, I kind of found what makes me happy, and I can use that in the patient's best interests. And just to finish, these pictures are all of SVNs at the time, but they're all fantastic RVNs now. And I just kind of wanted to finish on a note that my mum brought me up on, which is, if it is to be, it is up to me. So you really are in control of where you take your career, and just grab every opportunity that you can. If you want something to happen, you have to make it happen. If you want support, ask for support. If you want to travel around the world, buy that plane ticket. Nothing's going to happen until kind of you put forth the steps and you put in the motions for it to happen. So I just want to finish on that. There's a lot of things my mum, she's a bit of a hippie, she's told me, but this one always sticks with me. If it is to be, it is up to me.